today we're dealing with patient experience, at least that's the title of the seminar.
Julian, you highlighted the board leadership as a key ingredient in ensuring high quality care and good patient experience. Can you tell us how that works in your trust?
Yes, the board is responsible at the highest level for what goes on in the hospital, so it's absolutely essential that the board has good information and oversight about what's going on from boardroom right through to the ward, and that entails making sure that we're all adequately trained and expert in interpreting the data that comes to the board. We use what we call the quality account, which gives the board a whole series of information on key performance areas in terms of patient safety and quality.
What struck me at the public inquiry is just how much data the NHS collects. If I'd have known just how dangerous Mid-Staffs was, there's no way my mum would have gone into that hospital. Cure the NHS believes that anonymised SUIs, anonymised complaints, incident forms, all anonymised, should go into the local library on a 3-monthly, if not a monthly basis. And anybody going into that hospital can see, oh, Ward 11, it's got those complaints, those serious underward incidents gone on. Only then have we got an informed decision to go into that hospital.
I just wanted to respond to Julie's point, because here it is. As a member of the public, this is the volume I get of all the SUIs and all the incidents and the root cause analysis from the Homerton Hospital. So, you know, there's an inch-thick pile of papers that I get every month, and I'm able to discuss the data inside this book and discuss recommendations. But you know, what does a member of the public do with that? And even if you know it exists, the real question is, how do we translate that into something that the public can use?
But it's better to have that.
Yeah, no, absolutely. No, I think it's really progressive that, I don't know what happens at other hospitals, but it's really progressive that the Homerton Hospital makes this available.
I think getting that information and making it available is very important, but one of the things that we discussed on the table is developing a more equal relationship and ensuring that the health professionals have the attitude whereby they regard it as a kind of standard part of their business, if you like, to fully involve the patient. So you don't need to go and do the research in the local library, because the clinician who's talking to you will actually tell you what they know.
I think the work started by Wennerberg in Dartmouth showed that patient decision aids mean that patients get safer, more effective, better quality outcomes. I'd just be interested to know how many people are aware that 8 of those were published on NHS Choices earlier this year.
The question kind of presupposes that there are good methods for collecting information about patient experience and what can we do to collect more. And I think you have to take a step back and think, well, do we actually act effectively on the information we already collect? There's a National Inpatient Survey, it's run for 5 years. Every year it produces really fantastic information about patient experiences, and the performance of the NHS in that survey hasn't really moved at all in 5 years. So that's surely the bigger question that needs to be answered first, not how can we further measure stuff, how can we actually make the NHS respond on what it's already measuring.
Good point. Paul, for some people today, Patient Opinion was a new name. Could you tell us a bit about your organisation and how it works?
Patient Opinion is a website that anybody can use. It's freely available, so you can just go and see what people are saying. And it's a place where patients, service users, families, carers and staff can go and share their story of care across the NHS, across the UK. Patient Opinion is not intended to get a story from everybody. It will never be representative. It's always people who are saying thank you, which is about 45% of stories, and people who are dissatisfied in some way. So it's never going to replace surveys or be statistically valid. What it does is to allow people to have a voice, and in this day and age with social media, what they expect back is a voice back. They want a voice with heart, preferably from somebody that they know. They want Mary, who they remember as being the charge nurse on the ward, to actually come back and say something.
We heard from Paul around some of the developments about new media, that it's unstoppable and people are increasingly wanting to share and tell their stories through a number of different outlets. It's quite complicated for Trust to respond to all of those different sources of information, but they do need to. To take it on, and there's some real powerful ways in which they can begin to listen to those stories and track them and then respond to them. We also heard this afternoon about brand NHS, or lack of brand NHS, needing to have a clearer set of values and behaviours, recruiting for the behaviours that people that are wanting to work with patients and wanting to give something to them. We've heard in our seminars several contributors in the NHS talking about recruiting staff for the values that they bring to their work. Is that something that's important in John Lewis?
Absolutely, yes. Recruitment is very important, and it's important to reflect in our recruitment that we have people that with the skills to deliver great service and with the behaviours that reflect great service. Essentially, people that want to interact with other people. That's what retail is all about. It's all about talking to people and ensuring that they are happy with their purchases. So we would like to recruit people that get some enjoyment from that kind of interaction with customers, and also then we can help them learn the skills to continuously improve their service.
Just the one thing I took from John Lewis was the absolute seriousness of their approach. They took themselves seriously in terms of, we're here to improve the experience for customers and our staff, and therefore what follows from that is that they recruit for it, and every single person is recruited to be able to do that, and they're all trained and developed to enable them to do it. And that is what we need to do in the NHS, not leave it to people to choose to do it. We're a £100 billion business, and the consequences of failing the NHS are catastrophic, literally. So if John Lewis can do it, we should too.
Reflected a bit on the John Lewis idea that every partner is a complaint handler, and we were thinking about the much more extensive use of all of the tools that have been mentioned by previous speakers. That there are an awful lot of tools that are already available that people just simply don't know about them. So those are examples around experience-based design, carer cards, a range of examples that people could use. So
why do you think they don't get consistently used? The stuff's out there.
I think I think that does link to the question about professionalism, that actually people often don't think it's that important. Yeah. So that is something we definitely do need to tackle.
How does your trust ensure complaints are properly investigated and not handled defensively?
Very important, and like any organisation, we have our share of complaints and things do go wrong. The important thing is that the culture of the organisation is one that we prize in terms of being honest and open, and therefore we look at complaints as an opportunity to see not only what went wrong and how we can learn from it, but also to try and have a productive engagement with the family, the patient themselves. I meet with many patients and families in terms of complaint handling and resolution. We try to ensure that we give patients as much of an explanation as possible and try not to sound defensive, and that's a very important issue.
One of the ways in which the negativity around receiving and acting on complaints that's prevalent in the NHS could be combated would be less of a focus on number of complaints, which obviously is an issue, but more on how satisfactorily the complaints were resolved. So you could ask people, how well was that complaint resolved, and use that as a metric and actually reward staff for how well they're resolving complaints. I'm not aware of that process being used anywhere in the NHS, but I think it might help to change that.
Some mileage in that.
In that respect, we also discussed the rule within the more recent change to the regs, where you have 24 hours to resolve a customer service inquiry, or it must be counted as a complaint. And the problem that causes, picking up on something Victoria said in terms of that doesn't necessarily indicate a quality response, it also makes trust boards focus on the wrong thing because they're simply looking at the number. And we've heard about trusts who've actually talked to, spoke to their team saying, I want you to convert this back into a concern, this is bad news, we don't want the publicity that we're having lots of complaints, as opposed to, complaints are a good thing and it could mean you have good access. So there is something about the process there.
And that led us into thinking about actually what we should be measuring is not the level of complaint but the level of feedback generally. and that what we should be thinking about ways in which that can be made more public.
Do you think that patients are more willing, more comfortable with expressing a view about the care that they had after the event than at the bedside, for example?
I think you get different things. If on handhelds, on trackers, I think you get lots of useful information essentially about hotel aspects. Was it clean? Was it timely? Did I wait? All that sort of thing, and that's great. I don't think you will get people saying, I felt my consultant was rude, when they're still actually in their pyjamas.
Yes.
Or metaphorically in their pyjamas and still in outpatients. And I also don't think that often we know what we think of the care till a couple of weeks has passed.
And I also do a roving caring cafe round the bedsides, especially in care of the elderly wards. And you start off by getting feedback like, oh, everybody is marvellous, they're all wonderful, no problem at all. But when you having a cup of tea and they become more and more relaxed, they say, well, there was this incident the other night and I needed a commode and I'm afraid I wet myself because they didn't get to me. And other things come out when the situation is conducive to actually talking.
Of course, only if a minority of people will have the energy to post their stories at that point, but that doesn't really matter if what they're saying edges the system to better care. You don't need everybody. You need that passionate, thoughtfully passionate 5% of people who think, you know, my mum died in whatever hospital and it was awful and it was great, but I just wish that this bit was different, and I'm going to write this because I really want this little bit to be different. And they write their story, and then the system should take that and reply and make it better, because that will help the system, but it also helps this person here.
We've talked a lot today about complaints, how to generate them, how to deal with them. The one thing I think we haven't emphasised enough is the lack of time in the NHS people are prepared to say the simple word sorry. And I think lots of people want to hear that word. And we seem to have a culture where if you say sorry, you're somehow admitting medico-legal responsibility. And I think we get across to as many colleagues as possible, it doesn't cost anything to say sorry, you're not admitting culpability, but at least you're acknowledging that things went wrong.
Absolutely. Julia, would that have helped you make start a few more stories?
Yes, it would. It would have been nice to have had an apology, but the one thing that once you've been harmed or your relative's been harmed, what you want to know is that that's never ever going to happen again. Yeah. Lessons will be learned. And the way the public know that is by, I'll go back to this again, by having complaints published, anonymised complaints, so we can check back 10 years' time, a year's time, if that complaint ever happens again.
Yeah. And we heard from patients here today, they don't just want to know that the complaint has been addressed for them. They want to make sure that the trusts are doing something so it doesn't happen again for other people, and that's incredibly important. We've heard some themes this afternoon about making it easier for people to share their views and concerns, particularly in hospitals when they're vulnerable. We heard about the cafes, we've heard about the different outlets for patient stories, we've heard about the various mechanisms like Health Watch and the scrutiny committees. It's complicated, and there is a responsibility on organisations at the top of the NHS but also locally to try and stitch that up in the best way that we can. And then finally we heard a lot about the way that older people in particular and other people with long-term conditions are cared for.
There was an overwhelming feeling that we had to completely reprioritise the status and the importance given to caring for elderly patients in our NHS. It does need more staffing, more resources dedicated to it. But there was also a great sense of realism that if you're going to do that, that means that you might have to make some sacrifices elsewhere.
The NHS has to meet a set of public expectations, but with limited resources. When I go into John Lewis, I can make the choice whether to spend my money or not. When I have cancer, I don't want to have to make that choice. I want good, fast, effective treatment. But there are limited resources, and we have to engage with the public. We have to have a discussion about what should be done where, and make some of those courageous decisions as well.
But surely there will need to be a reality check. With all the will in the world, we all agree, I think, that change needs to come from within, leadership, bottom up, etc. But also the kind of reality check and the critical friend role of actually talking to NHS organisations and saying, what are you doing about that? Are you still doing this? That is a great expectation, I believe, of the new Healthwatch organisation. How do we make that real? And I share the concerns expressed earlier on that the current proposals for Healthwatch would not make it fit for purpose. It needs to be much more joined up. There needs to be guaranteed levels of resources consistently across the country, and it needs to be completely independent. If you like, as many people have said during the course of the inquiry, to be much more like what we experienced years ago with community health councils, a local identifiable one-stop shop, or to put it a more modern way, to do the formidable role that Cure the NHS has done, to be a local, trusted, outspoken, vociferous champion of patients and local people. As currently constituted, I believe it would be able to do that.
I'm not going to draw any conclusions today, that would be quite wrong, but just a couple of observations, I think. The first is we saw on one of our slides a tsunami. I've said this in a different language at other seminars, but I'm sure we all realise in this room, particularly those who've had bad experiences in hospital, but perhaps not all NHS managers know it. There is a tsunami of anger out there crashing down on the National Health Service. Why is it crashing down? Because there's a feeling, rightly or wrongly, that people are not being listened to. Had people felt they were being listened to, I very much suspect that I wouldn't have had to be employed running a public inquiry for what seems like a very long time now. But thank you very much for coming, and I think you have benefited at least as much as I have. Thank you.